ചെറിയ ജലദോഷം പനിയും പിടിച്ചു.
ആണോ?
സൺഡേയിൽ എന്തായാലും കുഴപ്പമില്ല.
ശബ്ദത്തിന് കുറച്ച് കുഴപ്പമുണ്ടല്ലേ? കുറച്ച് ശബ്ദം കുറച്ചൊരു പ്രശ്നം
ഉണ്ട്. We'll start in 1 minute's time, okay?
Hello.
Hello.
Sir, you can start.
Yeah. Just 1 more minute to start.
Okay, sir.
Yeah. I think it's already said 8:50. 2 minutes past 8:50. Okay, good evening to all of you. I think this is the 120th session on our challenging series. I will share my screen. As usual, I will start with a short case first. Is my screen visible?
Yes, sir.
So this is a story of a 45-year-old female. About 2 months back, she was noticed to be behaving abnormally in the form of episodic muteness and sometimes talking to herself. She started showing lack of self-care, a tendency to sit alone and not respond to others, and slowness in walking and urinary incontinence. She became bedridden for the last 2 weeks prior to admission. No headache or fever. She was shown to a psychiatrist and was being treated as a case of catatonic schizophrenia. So, story of 2 months duration, mainly behavioral problem in the form of severe apathy, muteness, and some depressive tendency, and bedridden following that. This is the video of the patient. He is conscious but resists eye opening. Eye seems to be elevated downward, which is episodic but all the time.
Kajamini.
Ocular epiphytic was absent. The video. Her lips are all rigid. She's got catatonic posturing of the left upper limb. She keeps the hands always like that. Clenched hand and into rest position. Right arm seems to dip down faster compared to the left side. She also tends to keep the lower limb in the first position most of the time. And most of the time, she tends to keep her head and eyes turned deviated to the right side. Reflexes are normal. Members were indefinite. So summarizing, she was conscious, versus eye opening, episodic tonic downward deviation of the eyes, focal focus was absent, tendency to keep her neck turned towards the right side most of the time, rigidity of both upper and lower limbs, hypnotic posturing of left upper limb and both lower limbs. On lifting her, both upper limbs are allowed to fall. Right upper limb seems to fall faster, indicating there is asymmetrical weakness on the right side. Feet are all slightly brisk and are indefinite. Occasionally, her eyes and neck is turned to right and remains that person for many minutes. So this is the story of this patient. Before I'll come to the asking you the localization of diagnosis, I'll just what is this eye sign which you need to observe? Initial one which you observe, not deviation of eyes downward. I'll show the video once again. See this one, eye movement. Sometimes it goes up, but most of the time it dips down. What is the eye finding? Any thoughts? That is ocular dipping. It remains deep for some time and comes back as sometimes goes and dips like that. There is not a specific sign. Many diseases can produce that. I'll come to that later. So what are the clinical possibilities in our patient now? 2 months history of behavior problem and bending into catatonic post-hand.
Autoimmune encephalitis.
It's a very good, strong, good possibilities for autoimmune encephalitis. Anything else? Pardon? I did not hear. When CJD? Okay. So these are so it's a basically subacute diffuse encephalopathy. Is there some problem in the audio? I cannot hear you well. The first person I could hear. This I could not. Am I audible to you all? What is the problem there?
Yes, you're audible.
Okay. So subacute diffuse encephalopathy with catatonic posturing with asymmetrical weakness. So first possibly should be subacute encephalitis, maybe autoimmune, non-paraneoplastic like NMD or paraneoplastic, or chronic infections like prion disease like CJD has already been mentioned. Other infections TBM, chronic viral infections like herpes, HIV. Then you should also keep the back of the mind. Some tumors can also present like that. Some days rapidly progressing tumors like multiple abscesses, metastases, present relatively rapidly. Lymphoma, especially intravascular lymphoma. And there can be an encephalitic presentation of primary CNS vasculitis. Primary CNS vasculitis can present like 3 patterns. One is encephalitis, other is a tumoral presentation. It can also present like a tumor-like presentation and a vasculitic presentation. So she came with the CT scan, and this is the CT scan of the patient. It is basically normal. MRI T2 weighted as well as the flare sequences are normal. What else you need?
CSF.
Yes.
Diffusion MRI, sir.
Okay, very good. Okay. So EEG was done. EEG showed basic wave complexes in periodic fashion at 1 to 1.5 second interval. What is the diagnosis?
Sir, diffusion MRI, sir. CJD.
Right. So always ask for diffusion MRI. But this is perfectly right. So never be satisfied with intermittent or flare sequences because only diffusion can pick up the abnormality in the same in encephalitis. Even in herpes simplex encephalitis, this is applicable. Early finding may be picked up only in diffusion sequences. So this is correct. Now you know what the diagnosis is.
CJD, sir.
That's a CJD. I brought this case, it's a relatively straightforward case. You got the point that always ask for diffusion weighted image. This kind of a periodic complexes does not always mean it is CJD. That can also occur with hepatic encephalopathy. Okay. So CJD can present with escatatonia. This is ocular dipping in leukocytal disease. And there are other causes of ocular dipping, like positive ischemic encephalopathy, pontine stroke, CJD, hypertension, Wernicke's encephalopathy, anti-MDA encephalitis, pinealoblastoma, and acute encephalitis. There are other ribome abnormalities which are described as periodic alternating nystagmus, upbeat, centripetal, rebound nystagmus. They may also develop supranuclear vertical case palsy, vertical slow saccades, and skew deviation. And one interesting phenomena which is described in CAD is called periodic alternating gaze deviation. That means sometimes the whole gaze goes to the right side along with the head, then comes to the midline, again goes to the contracting side. See here, for the first film, it goes towards the right side, eyes also get in that direction. Then it turns to the left side. This is called periodic alternating gaze deviation. So this is something is which the treatment resistant pressure again, remember the 2-3 important clinical points. The typical pattern of optical ribbon sign and hyperintensity in the basal ganglia need not be present in all CJD patients. Some of them may be confined only to the cortex, some of them only confined to the basal ganglia. So it may be only confined to the parietal cortex, some only in the temporal cortex, like that. The various patterns are described. There are some. There are 6 variants depending upon the genotype. That is, they called MM1, MM2, VV1, VV2, and MV1, MV2. This all depends upon the methionine value, the combination, the genetics. So depending upon the type, genotype type, the MRI picture can vary. This is MM1 type, M2 type, which involves both only the context and relatively spared. Here the MB type striatum, both striatum and parietal cortex is affected. MB2 type, thalamus also included. And VV2 type, the cortical ganglia is not affected, only confined to the basal ganglia. Then this is V1 type. No, we need not remember all these types, but remember that the abnormality need not be confined, need not occur in both basal ganglia and cortex together. Sometimes it may be confined to the basal ganglia, sometimes it may be confined to the cortex. So shall I go to the next case?
So treatment given.
No specific treatment was given. Because there is a poor prognosis, nothing can be done for the patient.
Okay.
Sorry, the triphasic complex is common in CJD.
Yeah, it is very common in CJD. Very common. The one clue is that it's a triphasic sharp waves which is more common in CJD. Whereas triphasic slow waves is more common in Americans. Very difficult to conceive. They can occur in 1 per second interval, closely mimicking a metabolic encephalopathy. I just remember one patient when I was in Kottayam Medical where I had seen a patient with altered sensorium of 2 to 3 weeks. He just had typical periodic complexes like this. So I diagnosed my CJD. 2 weeks later, the patient came walking to my room. Not even the friend. It was a case of a metabolic encephalopathy. So that confusion can always occur. At that time, there was no MRI or anything to confirm or refute our CJD diagnosis. It was not clinical. So these things you have to keep in mind. BJKC encephalitis also can produce FACV complexes. Shall I go to the next case? Okay. This is a long case, in fact. This is a 35-year-old man developed imbalance while walking for the last 6 to 8 months. He gave history of episodic headache, which is more on the left side for the same duration. His complaint was that when he stops walking, he tends to go backward and forward. Also felt by transcendence while walking. 2 months later, he noticed number of his hands whenever he was tensed, which has subsided with treatment. He noticed diplopia for the last 3 months, which is binocular, and images were separated horizontally and vertically. He was not able to see in which direction it was going. The last 6 months, wife has noticed RBD. For the last 2 months, his walking difficulty got worsened and developed urinary incontinence. I'll go back to the history once again. Total duration is about 6 to 8 months. Started as imbalance while walking and episodic headache. Then he noticed a peculiar phenomenon when he stops, tends to drift backward and forward. Tends to go backward and forward. I'll show the video. 2 months later, he noticed number of his head, which has subsided subsequently. Then for the last 3 months, he noticed diplopia, just horizontal, and the images were separated horizontally and vertically. He was not able to see in which direction it was. In the last 6 months, wife has noticed behavioral disorder and walking difficulty worsened for the last 2 months with development of incontinence. So I have divided the video into many sections to make it easy to understand. So this first part of the video.
He's got a condomini.
I'll be showing it again in later on.
Wouldn't okay.
You can time movements very closely.
Mollote നോക്കി താഴെ വെള്ളി നോക്കിക്കേ മുള്ളോട്ട് നോക്കേ
Look at this time. Look at the position eyes when you look to the right side.
ഒന്നാണ് ഒന്ന് ഇപ്പോഴേ ഇവരുടെ തുമ്പത്ത് നോക്കണേ വേറെ എവിടെയും നോക്കരുതേ തുമ്പത്ത് നോക്കണേ കേട്ടോ ഇറ്റ്സ് കമ്മിങ് ഡൗൺ ദാറ്റ്സ് വാട്ട് ഇറ്റ് നോക്കിക്കേ ഇനി നോക്കിക്കേ നോക്കിക്കൊണ്ടിരിക്കണേ വെള്ളം നോക്കണം കേട്ടോ that is coming down. ശ്രദ്ധിച്ചില്ല ഒന്നുകൂടെ നോക്കാം എട്ടം നോക്കിക്കേ മൂക്കിൻ്റെ എട്ടം നോക്കിക്കേ
Okay. Now I'll show all the video and then come back to the discussion later. The second part.
ഒരു പോയിന്റ് നോക്കി ഇവിടെ നോക്കേ
Doing the cover test. I'll show that once.
ഒരു പോയിന്റ് നോക്കി ഇവിടെ നോക്കേ ഒരു പോയിന്റ് നോക്കി
Third part. Fast seconds and pursuit.
സെക്കൻഡ് ഫുള്ള് മുകളിലോട്ട് പോകുന്നില്ല നോക്കിക്കേ താഴെ
Look everybody said.
ഇവിടെ റൗണ്ട് കോൺസെപ്റ്റ് കൊണ്ട് ഇപ്പൊ കിട്ടി മുകളിൽ നോക്കിക്കേ താഴെ മുകളിൽ പോകുന്നത് ഇറ്റ്സ് നോട്ട് ഗോയിങ് അപ്പ് സ്റ്റോപ്പിംഗ് മുകളിലോട്ട് നോക്ക് താഴെ പെട്ടെന്ന് നോക്കട്ടെ ഇനി ഇവിടെ നോക്കിക്കോ
Pursuit is normal.
Pursuit is normal. Pursuit is perfectly normal. ഇനി പെട്ടെന്ന് മുകളിലോട്ട് നോക്ക് താഴെ കണ്ടില്ലേ മുകളിലോട്ട്
Okay. Another part of the examination.
പല്ലിയടിച്ച് ഓടിച്ചത് പല്ലിയടിച്ച്
Other pages are all normal.
അത് തുറന്നേ.
He had some tongue tremor,
നാക്ക് നീട്ട്. ഇങ്ങനെ കാണിച്ച്, ഇങ്ങനെ കാണിച്ച പോലെ, ഇങ്ങനെ
which
കാണിച്ച്.
I did not pick up initially. And movements are otherwise normal.
കൊടുക്കരുതേ.
The motor system,
മുറുക്കി പിടിച്ച്.
bone power was normal.
വിട്ടോ. കയ്യിന് അത് കിട്ടിയില്ല. കൈ പൊക്കി. നൂർത്തെ. നൂർത്ത് പിടി. അത് വിട്ടോ. ബലം കൊടുക്കില്ല, ബലം കൊടുക്കാതെ. വിരലിന്റെ തുമ്പത്ത് തൊടണം.
He's got incoordination of both the limbs, slightly more on the left side rather than the right side.
മൂക്കി തുമ്പത്ത് അറ്റത്ത്. ഈ താളം പിടിക്കുന്ന പോലെ ഇങ്ങനെ ചെയ്യാം. മെറ്റൊക്കെ
It's more clumsy on the left side. The lower limb tone power normal.
ഈ കാല് നേരെ ഇതിവിടെ പിടിച്ചോ. ഈ കാല് നേരെ പൊക്കിക്ക് പിടിച്ചോ. മതി വിട്ടേ. ഇതും പൊക്കിക്ക്. പവർ ഈസ് ഗുഡ്. വിട്ടോ. മുകളിലോട്ട്. ഇത് മുകളിലോട്ട്. ചവിട്ടിക്ക് എൻ്റെ കയ്യിൽ. ഇത് തന്നെ ചവിട്ടിക്ക്. മതി. കുറച്ച് തുറക്കാം. മതി വിട്ടോ. ലൂസ് ആക്കിയേ.
Plexus were normally elevated, slightly bristling, if you want to say, but that is normal. Blood pressure were intact. Knee and ankle legs are also normal.
ബലം കൊടുക്കണ്ട.
Pandarus flexor.
ഇത് ചുമ്മാ ഇട്ട് ബലം കൊടുക്കണ്ട.
There is heel shape incoordination both sides, but more prominent in the left side compared to the right. There is more. Since this is extension is normal, well, she could appreciate. It's also the pain sensation.
അറിയാലോ അല്ലേ? ഞാൻ എഴുന്നേറ്റ് നിൽക്കണേ.
You look at the gait, there's very funny gait and stance. When he stands, he goes backward. Like that.
ബാക്കിൽ ഇപ്പം വീഴത്തില്ല. എവിടെയെങ്കിലും പിടിക്കും. ശരി, മൂന്ന് ചുവട് മുമ്പോട്ട് വെച്ച് മുമ്പോട്ട് നടന്നേ. ചുമ്മാ സാറ് നടക്കുന്നതാണ്. ഇനി ഇവിടെ നിന്നോ അവിടെ നിന്നോ. അതിന് തിരിച്ചു വാ, തിരിഞ്ഞ് നടന്നു ഞാൻ പറയുമ്പോൾ നിൽക്കണേ. നിന്നോ അവിടെ നിൽക്കും. ബലം പിടിക്കണ്ട. നടന്നോ.
When turning it is good balance. When stands with the feet first goes back again. And walking was effective. Okay. On the second day, some other abnormality was noticed in the eye. It got a side beating disturbed to the right, not possible looking straight and fast about the beating to the right. Primary position is not there, not possible looking to the left side. The second day, they walking gate of liberty in the second day, permission the hospital ward. And after 1 week, we came to follow this one. This was present initially also, which I did not the initial examination. It's got a trunk tremor like this, going forward and backward. So, like I say, this is a difficult case. So I thought I will find out what are the findings observed in this patient one by one. Let us analyze each of the findings. Search for the video and then ask that one. Otherwise, we tell everything together, it will be difficult. First, let me analyze the eye movement of the magnetics. So, what is causing? Yes, for diplopia, vertical as well as horizontal. That's what is there. Now, let us see. Let's analyze diplopia. Let's see the freeze frames of each position. He's looking to the right side. What did you observe looking to the right side? Is it in alignment or in difference? The left eye seems to go up, right eye seems to be less compared to the inlet. And the right eye is down, the left eye is up. Look to the left side, nothing abnormal, both are in parallel and no, but it is conjugation. Looking up, nothing abnormal. Looking down also, there is no disconjugation. Looking to the up and right and up, this is a position, up and down. And this is the position in which the maximum disconjugation is obvious. So what could be the site of lesion for this? The pathology may be either the right eye or the left eye. If it is the left eye, it is a weakness of the depressor in the adducted position, that is superior oblique. Or the right eye is the culprit. The elevate is defective in the abducted position, that is right superior. Yes. Am I right? Am I audible? Nobody is telling me anything.
Yes, sir.
Okay. So it could be, we don't know which side is affected, whether the left is one, right is one. More vertical separation was looking down and out, probably the superior oblique is a culprit, but one cannot be said. So it could be left superior oblique weakness or could be right superior rectus weakness. So if you're not convinced about that vertical disconjugation, you can identify the test. So looking to the, you should be looking to the right side and then doing an alternate cover test. You see what is happening now. On covering the right eye goes up. On the right eye,
It's coming down.
I'll show you once again.
നോക്കിക്കേ
Now in the left eye, right eye goes up.
നോക്കിക്കൊണ്ടിരിക്കണേ പെട്ടെന്ന് നോക്കണം കേട്ടോ
On right eye, left eye goes up.
ശ്രദ്ധിച്ച് നോക്കിക്കേ
So on covering the left eye, right eye goes up. Right eye, left eye.
നോക്കിക്കൊണ്ടിരിക്കണേ
Confirming the vertical misalignment only. So whenever you got a doubt regarding whether there is only mild disconjugation, always you can confirm it by doing this kind of a cover and cover. You can find the what's called movement redress. I will move, catch up to target. So the eye, the macula is focused on the target. On looking, sometimes looking straight with both, sometimes we are convinced whether it is there or not. So here's second thing, here's another type of eye movement on the uncovered test. Let us see the video once again. This video you showed before.
ഒരു പോയിന്റ് നോക്കി ഇവരിൽ നോക്കേ
Looking straight, see what is happening. I'll show once again.
ഒരു പോയിന്റ് നോക്കി ഇവരിൽ
Right, cover the right eye, left eye goes out, left eye also goes out. Whichever is covered, the other eye moves out.
ഒരു പോയിന്റ്
The right eye, left eye goes out. This is the left eye going out.
ഒരു
So what did you observe? On covering the left eye, the right uncovered eye moved out. On covering the right eye, left uncovered eye moved out. That patient had a convergence studies. Convergence, even though not obvious, it may be some convergent position over there. On straight looking, we are not able to make it. But on cover and cover test, we know that it's got that one eye is moving up, moving out to catch in the second. This that convergence due to weakness of either lateral rectus, which we do not know, or due to some convergence calcium occur, suggesting a mild convergent strabismus, either lateral rectal weakness or vein spasms. If you are not following, if you ask me to stop, you can stop it. Always ask me to stop so that I can show the video once again. Okay. It's again to find out any subtle weakness of the lateral rectus or overaction of the medial rectus. So then coming to the abnormality of the vertical line, let us see this video once again, which I've already shown.
താഴെ
Look, see what is happening looking up.
ഇവിടെ
It's low at hypermetric side.
ഇവിടെ
And it stops it.
നോക്കിക്കേ.
Read what is happening
മുകളിൽ മുകളിൽ
to the eyelid. I'll show once again.
താഴെ
Eyelid is coming slowly much lower than the eyeball movement. Relax behind.
താഴെ മുകളിൽ
Looking up, it is not going.
മുകളിൽ
There's a break in between before it goes up. It goes to
താഴെ
when there's around the whole side, it is not easy to make control.
ഇവിടെ നോക്കിക്കേ. താഴെ മുകളിൽ മുകളിൽ
So what is abnormality here?
താഴെ
That what we observe, when taking hypermetric circuit, or looking up, it stops and moves up, but it's not moving. The second is the Collier sign, the eyelid retracts and looking down. Did you see that? When it starts to look down, eyelids lag behind the eyeball movement. So this is regarding the first abnormality. There is another eye movement abnormality which was noticed in the second day. This video also shows,
ഇവിടെ നോക്ക് മണി
but the jet is turned to the right side. Notice
ഇവിടെ മുകളിൽ താഴെ വലിയ
So what will be the reason for that? When you get a nystagmus beating only to one direction, not to some other direction. What do you call that nystagmus?
ഇവിടെ നോക്ക്
Like a very, what would be explanation to the horizontal jack nystagmus? Only you look to the right, not the primary position, not look to the left side. You can see the peripheral labyrinthine nystagmus. The peripheral labyrinthine nystagmus is the past components to the contralateral side. And in early vestibular dysfunction, you present only you look into the contralateral side, not present the primary position or only look at the same side. That's for the grade 1 peripheral labyrinthine nystagmus. In a more severe form, it also appears in the primary position. The severest form, even on looking to the same side, nystagmus meeting with the contralateral side. That is one possibility. Then the other possibility is what is called pseudo-vestibular nystagmus, seen in classically seen in Latin syndrome. It mimics something like a peripheral vestibular nystagmus. An entity called gaze paretic nystagmus, that is on recovering, patient recovering with the gaze paresis, local muscle weakness, and rarely parietal nystagmus. That part I will skip. Another incidence about pseudo-vestibular nystagmus is a central pathology of acute vestibular syndrome characterized by unidirectional nystagmus, mimicking acute peripheral vestibulopathy. The nodulus, which is separated by the medial pica, is a critical structure in the direction-specific pattern of organoid dysfunction. It involved pathologically the patient presents with controversial, so that you can skip. So this classical side is nodulus, but also can be seen in vestibular nucleus lesions. Also, you can have a pseudo-vestibular nystagmus. The next question. So in this patient can be due to vestibular nucleus involvement. We found some weakness of the extraocular muscles, made the cover and cover test. Can the extraocular muscle produce nystagmus? Or does not produce nystagmus? Okay, let us see. This particular lady is, you must have seen, I have showed sometime long, 2-3 years back. She had left ternal pulse.
ഇങ്ങോട്ട് നോക്കുമ്പോ
The process that I
ഇടത്തോട്ട്
say,
ശ്രമിച്ചേ.
action is restricted. Pressure is restricted.
മുകളില് മുകളിലോട്ട് നോക്കുമ്പോ താഴെ മുകളില് വലത്തോട്ട്.
She has no nystagmus. She recovered from the third now and see what has happened.
ഇവിടെ നോക്കി.
Left ventricle is not totally recovered, but almost totally recovered.
റൈറ്റ്
But look at the right eye, what is happening? She has got a nystagmus.
വിരലിൽ തന്നെ നോക്കണം.
See the nystagmus on the right side? Not muscle on the left side. Again, you can find the nystagmus.
The left eye is at a lower level. നോക്കിക്കൊണ്ടിരിക്കുമ്പോ
Okay, so that means this patient had left middle rectus weakness, and subsequently the nystagmus did not was there earlier, was not present earlier, developed later with the recovery of the middle rectus. So what did that you do? This is one example of a gaze paretic nystagmus. Gaze paretic does not necessarily mean that it should be gaze palsy. It can be extraocular muscle weakness also. Now, may I ask you how to confirm now this issue of extraocular muscle weakness missing nystagmus? Any bedside test you can do? You confirm whether it is due to the muscle weakness or due to some central. So we can anyway argue that this patient has got in addition a vestibular nystagmus or a brain stimulation to the vestibular nucleus producing nystagmus. Already she has got a brain stimulation, but their nerve is affected. But activity is only due to ocular, what will you do? Yes?
Action.
Close one eye, very simple.
ഇവിടെ നോക്കി.
See what clinical test confirm. It's simple. This is only because when the patient is putting extra input to the quadrilateral eye, I'll explain that. See what
നോക്കണമേ.
it was.
ഇവിടെ തന്നെ നോക്കിക്കൊണ്ടേ ഇരിക്കേ.
Close the left eye. Nystagmus is
നോക്കിക്കൊണ്ടിരിക്കണേ കേട്ടമ്മ.
nystagmus. Again close, nystagmus appears.
നോക്കിക്കൊണ്ടിരിക്കേ.
Why it is occurring is because
നോക്കിക്കൊണ്ടിരുന്നേ.
the left middle rectus is weak, it's not perfectly normal. So we are putting extra effort on the middle rectus to look towards the right side. The extra impulse also goes to the right lateral rectus, which is the yoke muscle. And according to the Herring's law of equal innervation, the same extra output also goes to the right lateral rectus. So that will produce the exaggerated nystagmus, ocular nystagmus. When you block one eye, that effort is not there on the right lateral rectus. So extra effort is not there. So you get a nystagmus. So this is one simple bedside test by which you can say whether such ocular movement abnormality which is seen in extraocular muscle paralysis is due to the muscle weakness or not.
നോക്കണമേ.
So what is this gaze paretic nystagmus? It's a type of nystagmus that results from weakness of extraocular muscles. Typically occurs during recovery period after central gaze palsy or other gaze paralysis such as myasthenia gravis or Guillain-Barré syndrome. This patient is unable to maintain eccentric eye position. Initially, little or no nystagmus may be present. However, as the eccentric gaze is held and extraocular muscle fatigue, nystagmus may start to develop. With horizontal gaze, the amplitude of the past phase of the abducted gaze is often greater amplitude at that of the abducting eye. This is due to the greater fatigue of the middle rectus. Okay. So that is our, so most likely our patient had a gaze penetrating distance, the horizontal distance between one direction. We need not necessarily implicate a visual pathology. Now you have to find explanation why our the patient should have a gaze penetrating distance when the patient did not have any medial rectus or lateral rectus weakness. And why should he have any gaze penetrating distance? So is it due to the right lateral rectus and left medial rectus weakness in our patient? But there is no weakness in our patients. It's not possible. It can be due to convergent spasm. Possible. It can produce apparent weakness in the lateral rectus due to so-called pseudoabducent paralysis. See, what is pseudoabducent paralysis? That there is already a continuous spasm of the convergent system. If you look laterally, the abduction is restricted by the convergence pull. Lateral rectus will not move fully. That is called pseudo-abducent palsy because the convergence is preventing the full abduction. In such a situation, also you can have nystagmus, so-called gaze penetrating nystagmus. Even though it is not the case paresis, it is because the apparent paresis due to the convergence spasm. Okay. That explanation is possible in our patient. So convergent spasm, this is what case report, and this is the video of this patient. Lady had convergent spasm and has nystagmus from the other direction.
All the way? This way? Is that moving your head? Good. And down, down, down. Down, down, down. There you go.
But the other phenomena which I've said is what? I tried to explain each ocular finding by the site of lesion which is feasible in our patient. And you need to notice eyelid retraction. Now, when you look down, the eyelids are coming slowly down. What could we do to that? That's called the Collier sign. And where is the site of lesion for the Collier sign? Collier sign is
Dorsal midbrain, sir.
Dorsal midbrain.
Absolutely right. And what's exactly the site of lesion in the area? That is due to the lesion of the nucleus of the posterior complex. So I will explain that. There are groups of neurons in the dorsal midbrain called the M neurons, the function of which is to coordinate the eyelid and the vertical line. So when you're looking down, the eyelid has to come down. Looking up, the eyelid has to go up in a synchronous, simultaneous fashion. That coordination is maintained by these M neurons, which the caudal center nucleus are in the LPS, and the third nerve subnucleus superior and inferior oblique. So this coordinates the vertical eye eyelid. These M neurons are modulated by the nucleus of posterior combination. When these lesions of posterior combination, as you said, dorsal midbrain, what happens is that this coordination is lost. Eyelid will not follow the eye globe. So you can have a cornea sign. So that's the explanation of the dorsal midbrain. So in summarizing, what are the findings in our patient? Left superior oblique or right superior rectus palsy. Because of the discontinuation look to the right side. Convergent strabismus producing esotropia. Hypermetric vertical saccades. Collier side. Side beating nystagmus to the right side. Now let's come to the tongue abnormality. Other findings in this patient. What is this abnormal movement? What do you call this? What is it known as?
Trombone.
This is called the trombone. Trombone. That the causes of trombone later on. Let us analyze the rest of the examination. She has got on standing. What did you find? The patient going back in few steps. He could maintain the posture in the erect position. It's called retroflexion. And there is bilateral limb ataxia lymphodenum. So these are the abnormalities. So where do you think want to put the lesion in this patient? I mentioned many things. When you want a preferred site, can you explain everything by a single site?
rostral midbrain,
Correct. You can explain everything by a rostral midbrain. Rostral midbrain near the periaqueductal region. You can explain the cochlear side. You can explain the superior spinal pedal. You can explain bilateral ataxia. You can explain the partial subnucleus involved in the third lobe account, the superior rectus or the inferior weakness. You can also explain the convergent spasm causing the so-called nystagmus. So everything can be explained in the dorsal midbrain region. So dorsal midbrain, the diplopia can be due to what? Involvement of the left third node subnucleus supplying the right superior rectus. We usually thought either right superior rectus or left superior oblique, or the left fourth nerve after crossing, or right fourth nerve nucleus. You know why right fourth nerve? Because right fourth nerve is supplying the left superior oblique, or the fascicular affection of the right nerve. So both way you can explain that. Convergent spasm to account for the esotropia and the pseudo-gaze-parating nystagmus. Hypometric circuit, you need to separate the connection between the F1 and the posterior locomotor region to the RAM. Cochlear sign due to lesion in the posterior condition. Bilateral cerebellar ataxia, crossing the hypersensitive epidemic. Due to lesions on the pedunculaire nucleus. The postal imbalance I will tell you later on why the retrobrushing occur. So coming back to the case, what are the clinical possibilities?
Mass.
6 months history.
soil,
Pathology there, no? So the common things are common, maybe glioma or a granuloma. Chronic infections like tuberculosis or fungus. Whipple's disease is another site which can occur. Jacob-Crusoe disease, Neurology syndrome, Anaplastic syndrome is another one which you have to keep in mind. Or mitochondria. These are the various, mitochondria is less likely. These are the various possibilities so that we keep in mind when there's some acute progressive brain stimulation. So what is
pineal tumor,
yeah, of course. Yes, I forgot to mention that. Translation glioma, granuloma, or a pineal tumor. Okay, what investigation? MRI, no? MRI, this is the MRI, this is the flare sequence. Coming from below. Spinal cord, medulla, mid pods, lower, mid and upper pods, middle, and the thalamus. This is the coronal region of interest. This is sagittal T1, spinal cord, down with it. So anything abnormal in the MRI?
No, sir.
Normal.
Any abnormality in the midbrain aqueduct, sir? Yes,
Yeah, there is something very funny here. Actually, something around the aqueduct. So I repeated the MRI with 3T with the contrast. We leave it, we get it. And this is a flare. This you can clearly make out this hyper density here. Surrounding the aqueduct, as you mentioned. The thalamus is normal. Contrast, there is no contrast enhancement. That region of interest, there is no contrast enhancement.
sir. T2 sagittal also showing, no, sir? Coronal, sorry.
Coronal, I don't teach you coronal. Not very convincing. Not very
It's the middle one, sir.
It's not. Yeah, there is some session, but not very convincing. That part.
Sir, that periaqueduct of high hyperintensity in many MRI will see, sir. In we have done for other purpose also.
Yeah, you're right. That may not just a full, but this we abnormal in this paper.
Demyelination.
Could be demyelination, but history is not favoring demyelination. 6 months history of progressive illness. But you can argue it may not be abnormal. I agree with you. There's no contrast enhancement there. If you look at the T1, that area is hypodense. The other areas are normal. That area which I suspected was hypodense. Hypodense. That's another clue which I thought this might be an abnormality there. But that same area which is hyperdense in prayer is hypo in T1. Even this patient has find there are undoubted legal findings pointing to the membrane. And this only abnormality we found there may not be there, but we have to have a final explanation. This is a contrast, sagittal. No other abnormality. This is I thought was abnormal. Okay. So what are the investigations you need now?
CSF analysis, NMO antibodies.
Okay.
And VDRL also.
Okay. So blood picture, routine, RFT, LFT, electrolytes are normal. CXR, ECG normal, ASH normal, HIB negative, angioplastic negative, serum lactate normal. Ogiriscopy for HP for Trophrema, Pipille for Whipple disease was negative. What else you did? CSF emission. CSF TC2 cells, protein 98, glucose 77. What else you did?
And NMO, sir.
NMO was not done. The taking picture was not, that finding was not favoring, typical appearance of a NMO appearance in the brain stem. Moreover, the clinical picture also not progressive illness. Anyway, that should have been done. CSF was divided into TPHMs also said not in the result. And serum was sent for VDRL. Both serum and TPHM was positive in the brain. So, is it a case of neurosyphilis?
Possible, sir, because this tongue tremor is described in.
So, this is a very strong, we are not 100%, we cannot say it is syphilis, but I'm also telling there is a high likely possibility of neurosyphilis. Because the CSF had shown clear cytosis, that would have an added point. We cannot 100% say it is neurosyphilis or not.
Tongue tremor is described. Trombone tremor is.
Yeah, that's correct. Perfectly. Trombone tremor is classically described in syphilis. In fact, patient was taken in lines of neurosyphilis, but he did not respond, ultimately succumbed to illness. So we are not 100% certain either way, but this case is actually brought to find out the localization and the possibility of keeping the back of the mind. Now, what was the true to suspect syphilis is the trombone tremor. And what is this trombone tremor? Trombone tremor particularly involved a darting movement of the tongue in and out of the mouth when the patient is investigating the tongue protruded. This sign may be seen in coliform movement disorders such as Huntington disease and neuroendocytosis as well as tardive dyskinesia. This is classically described in cases of neurosyphilis. Rarely, it is also described in as a new clinical site for significant metabolic conversion vitaminization. So the case report. So what are the other causes? I will show 2-3 other videos where I have seen this kind of a thrombotic. This patient, before that, what is this other abnormality which you can see in the orofacial region in patients with neurosyphilis? Any idea? And this sign in neurosyphilis. As if we're chewing a candy.
Okay, sir.
This is called candy sign. Candy sign is episodic, not rhythmic, brief, small amplitude contractions of the left orofacial muscles. Often at rest, and when the patient speaks, resembling movements same to sinking a candy. Although sometimes a grimace-like movement is noted, this phenomena seems to be distinct from pluripotent dyskinesia, which tend to diminish when orofacial muscles are activated and are commonly associated with hyperkinesia. This is what useful bedside clue which you have to always look for. Say Meek syndrome and idiopathic orofacial dyskinesia versus tardive dyskinesia. In tardive dyskinesia, the movements will stop when you ask the patient to speak or the patient to eat or do some activity with their tongue. On the other hand, Meek syndrome that is not seen. That is what a clue to differentiate from tardive dyskinesia. There are other causes of trombone tongue. Trombone tongue, it can be seen in acquired neurosyphilis. The other movements seen are trombone tongue, stereotypical dyskinesia or orofacial chorea, and T-side ghost tongue. This lady had ambisomnia, tardive dyskinesia, especially like trombone.
ശരിക്കും തുറക്ക് അതിന് നാട്ടിനിട്ട് നാക്ക് അങ്ങോട്ടോട്ട് തള്ളിക്കുമ്പോൾ ഇടത്തോട്ടും വലത്തോട്ടും കണ്ണു തുറന്നു കഴിയുമ്പോൾ അത് ചുമ്മാ ഇരുന്നേ ഇനി വാ തുറക്ക്.
This is another negative tremor. You can see that not only the tongue, the mouth also having tremor.
നാക്ക് അങ്ങോട്ട് തള്ളിക്ക് എടുത്തോട്ട് വലത്തോട്ട് ചുമ്മാ വായടിച്ചു ചുമ്മാ വായടിച്ചു ചുമ്മാ
When you look at the floor of the mouth, it goes on having a common like mode. Did you see that? The floor of the mouth is moving up and down like that. Again, you have the rhythmic contraction of the myofibroid muscle. So when you whenever you get tongue tremor, always keep tardive dyskinesia or dumping, which is one most common problem. So coming to this patient, how to diagnose a neurosyphilis is by reactive serum troponin test, which is present in our patient. Symptoms and signs of neurosyphilis, yes, possible. Then reactive CSF-VDRL or CSF-WBC more than 5 microliter or CSF protein. So that is the third criteria we are not satisfied. So if a CSF is showing more than 5 cells, then it will have been suggested by neurosyphilis. Okay, so any questions?
Sir, regarding nystagmus, sir.
Yeah, please.
Sir, regarding nystagmus, while routinely checking the patient, sometimes we see transiently side to side between nystagmus. In the routine checking for other examining for other patients also. But that is transiently seen. On repeated testing, that may not be seen again and again.
Okay, I'll tell you. One thing you have to keep in always mind is that when you look for the nystagmus, see that your finger is in the, it should not be too close to the patient. It should be seen in the binocular field of vision. It should not go beyond 60 degrees. If you take that far out beyond 60 degrees, you can find some nystagmus checks. So that point you have to keep in mind. That is not true nystagmus. Then other thing is that a fatigability of the ocular muscles sometimes can produce excessive eye strain, can also produce nystagmus, but that will not be long lasting, only for a short period of time. So they are physiological phenomena, not abnormal. That may be the reason for nystagmus occasion.
Okay, sir. Okay. Thank you, sir.
The call an abnormal nystagmus should be persistent, consistently persistent. And second thing, you should not take them. 2-3 important points. It should be not very close to your nose, at least beyond about one foot away. You keep your finger close. What happens is that you're reducing a convergence. Reduce a convergence, and you ask the patient to look laterally like that. Again, the previous problem will come. There's a convergence, and you are asking the patient to look laterally. Lateral access is prevented going fully, and you get a transient unilateral nystagmus. If you keep the finger far off from your body, it should not go beyond 60 degrees. If the nystagmus is present, that should be taken as a persistent. Taken as a no.
Okay, sir. Thank you, sir.
Any other questions?
How
Recently,
he died, sir?
Yeah,
Cause of
please.
death, cause of death.
I did not hear first.
Death, how he died?
No idea, because he went there. And the bystander came, they were very poor people who cannot come every time to the hospital. So the bystander came, he was too bedded, and they took to a local hospital. And what exactly the cause, I don't know. But one thing is sure, he did not respond initially. But he came up to us and said, no, absolutely, yes, he should be arrested. That's not no.
but at this stage, it may not respond to penicillin also.
Yeah.
Late stage.
He may not, at least he should be arrested. No, that did not happen.
So recently, I had one patient with a similar tongue tremor. CVJ was normal, medial was non-reactive, but his thyroid function was highly abnormal in favor of thyrotoxicosis, and that trombone tremor disappeared with the treatment for thyrotoxicosis.
Okay, that's a good point. Any other question?
So could it be a paraneoplastic, sir? What about the role of giving any steroids in this patient?
Neoplastic is a possibility which can like I told you, hepatitis is like anti-MA, anti-Q, anti-RA can produce paraneoplastic, but the presentation is slightly different. There's RA present with obstructive myoclonus syndrome, or syndrome present with membrane extending onto the ocular gaze palsy syndrome. So possible, their MRI appends also will be different. Here the paraneoplastic antibody profile was said which is negative. And whether it's a possibility, GLOT5 that can present the brainstem signs like this, yes, can present. But these antibodies are all not there.
Anti-TPO can present no, so cerebellar ataxia with brainstem symptoms.
Right, they can present several attacks and brainstem symptoms. They can present. It's red medial and TPH positivity, which took us 3 times earlier in some case.
And we can expect some pupillary abnormality also.
Yeah. But this patient did not have any definite pupillary abnormality sensing and ARP. But that need not be there all the time. Okay. Actually, I'll skip this topic and took this sense regarding what is causing the proportion. I'll skip that thing. Okay, I'll finish with the short case also. Okay. This 48-year-old male is still neck pain for the last 4 years, back pain for the last 2 years, pain on both thighs for the last 1 year. Pain was localized to the above region without any radiation. Pain did not increase by coughing and sneezing. Back pain was more when he gets up from bed or when he lies down from the sitting position. When he gets up from bed, more when he lies on the sitting down position, he more pain. Thigh pain was more while squatting. No history of any sensory complaint or improved weakness. He was seen by an orthopedician and was put on treatment with no significant improvement. He was subsequently seen by a rheumatologist. He got some relief in the treatment, but the pain returned again on stopping analgesics. He was referred to me to rule out any neurological cause for his pain in the neck and back. So this is it's a short case. I will run through. Subject tone power was normal.
പിടിച്ചോ ഈ കാല് നേരെ പൊക്ക 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 മതി വിട്ടോ ഇതും പൊക്കിക്കേ വിട്ടോ ആദ്യം മുകളിലോട്ട് എടുത്തേ മുകളിലോട്ട് എടുക്കുക അല്ല പൊക്കി പിടിക്കേ ഇതും പൊക്കി പിടിക്കേ പൊക്കി പിടിച്ചേ മുകളിലോട്ട് പിടിച്ചോ വിടരുത്
normal.
എൻ്റെ കയ്യിലോട്ട് കിടക്കട്ടെ കേട്ടോ ഒന്നൂടെ മുറുക്കി പിടിക്കേ വിട്ടേ ഒന്നൂടെ മുറുക്കിക്കേ വിട്ടോ അതേമാതിരി ഇത് കൈ മുറുക്കിക്കേ വിട്ടോ
There was no sensation was normal. Not representing that.
ഒരു വൈബ്രേഷൻ അറിയുന്നുണ്ട്
There is no pain. SLR was negative. Lift up the leg, combined a pain in the back. Back was slightly positive because he could not get fully under on the left side. Right side he could do that. He was completely resisting the movement. Because where is the pain? He's pouring down to the hip to the back.
അവിടെ എന്നാൽ താഴ്ത്തിയിട്ട് വേദന എടുത്തിട്ട് താഴ്ത്ത് മുഴുവൻ മുട്ടിച്ച് താഴോട്ട് മുട്ടിക്കാൻ നോക്കിക്കേ.
He could fully apply to the. See the pain he is getting up. See the severe pain getting up the back of the trunk. Actually, it relieves pain because of the pain. He is completely pain over that area. This area, this time get the pain. Okay, what do you think?
Ankylosing spondylitis.
Sacroiliitis.
Sacroiliitis. Okay. Which is done already, came in 3 weeks back. It's got MRI done. Normal. Okay. This is the T2 axial. Normal. So in fact, rheumatology is just suffered by rheumatologist. So what the abnormality found is here, the only abnormality CSF was 60, otherwise converse normal, CRP was 50, serum creatinine SCPT normal, ACCP negative, rheumatoid factor negative, ANA negative. So that's referred by the rheumatologist to you. Then what will you do? Make tests for all negative.
HLA B27.
HLA B25 negative. So what do you think?
EMG, sir.
Pardon?
EMG, sir.
EMG for what?
Any continuous motor activity, it may tell us this person syndrome.
Correct. EMG, it's exactly.
Yes.
I'll tell you what thing. I thought he maybe has a fibromyalgia and put him on treatment velocity. But I want to rule out certain things. As Dr. was telling you about EMG, hypothyroidism about to pull out, hyperparathyroidism about to pull out, Stevens syndrome is another thing about to pull out. So set for serum calcium, diet, CPK normal, TSH normal, magnesium normal. Parathormone is also normal. So I did EMG the paraspinal, which I am not showing you. It was normal. There was no continuous motor activity. As you correctly said. It was spontaneous motor discharges. So I put him on pregabalin and duloxetine. He came for follow-up after 2 weeks with no relief. What to do? So like HLA B27 was negative. And then subsequently.
So MRI of hip was done, sir.
Okay. That's for you. So in fact, I told him I don't know what you're here. So let me team and discuss with the radiologist, interested physician in the complete conclusion. So in fact, I examined again on the second day of admission, we called him for admission. I found some restriction in the lateral movement of the neck to either side. With the positive capitis bilaterally. So I put the whole spine CT once again and an MRI of the hip joint as the doctor was insisting. The whole spine MRI, this is the normal dorsal spine. Normal cervical spine. But on true scrutiny, we found that irregularity of the SI joint on the left side. This is SI joint. Subsequent iliitis is there. And look at the irregularity at which the cervical joint there. And it is in some places it's in bilateral. Here you get to the costovertebral joints. Screening MRI was done for that with the still sequence. So this again find out the ideal sequence is still sequence, which often we report about find out again. No edema. And you find hyperdensity in the epiphyseal joints as taken information. This is a normal still sequence compared with the normal abdomen. You can find this is the normal one. This is the hyperdensity in the hypophyseal joints. Hyperdensity in the posterior part of the vertebral column. This hyperdensity in the posterior part of the narrow pedestal sequence. And the MRI of the hip joint. Synovial synovitis and edema. Bone per se is normal, but the joint is abnormal. So edema and synovitis are both hip joints. So this is the input. Bilateral attack is joint narrowing, C1, C2. The bilateral costovertebral costovertebral joints. So I repeated the ESR, CRP, RFX, anti-CCP, HLV 27. ESR is gone up by 22. RFX is now positive, 14. But only marginally positive. But anti-CCP was negative. HLV 27 was negative. So I put the patient interpretation with remarkable improvement. So patients referred back to the rheumatologist with suggestions and about hypermobility. So in fact, I bought this case because I made a mistake in making initial diagnosis of fibromyalgia, which is it was a case of some kind of inflammatory spondyloarthritis.
Sir, one point.
Pardon?
One point, you see, in ankylosing spondylitis, the earliest joint to get involved is sacroiliac joint.
Correct. We had in fact came with the neck pain first. Neck test is the sacroiliac joint, as you said. But in only 3 weeks, actually we was negative, but they understood that possibility that this is strong I keep in mind aggressive spondylitis.
The initial MRI should have picked up now, sir. They do the sagittal also, no, sir. First MRI.
MRI was normal. They did MRI from outside was keep it normal. They showed MRI.
But if they do the lumbar spine, they will cover sometimes the sacral joint also. We can see them, no, sir.
But in early stages, it may not be detected. Early stages.
In fact, no, I don't think to find a more abnormality in the CT. For that, the radiologist should meticulously spend time looking at the joint. See, here what I did was that I called the radiologist. They checked the whole spine. CT the whole spinal stain. Look for each costovertebral joint. Which radiologist look for each costovertebral joint. Other joints, the vertebrae and everything were normal. This is perfectly normal. So particularly look for any costovertebral joint abnormality and background abnormality.
So how long we will give indomethacin? That is the problem.
So I gave for a shot. I admittedly gave it, next day is pain. Next day.
How long to continue?
No. I'm not going to manage the patient. I've sent the patient to the traumatist. So idea was to start the patient with methotrexate and then withdraw methotrexate. That's what we usually do with inflammatory arthritis.
There was a clinical point, sir, like for this patient history, his maximum pain was on lying down from the sitting position. That was in a sacroiliac joint.
Okay. I didn't know that. That's a part where sacroiliac joint. Okay.
But that you can get in any inflammatory arthritis.
On sitting and lying down, pain occurs mainly in the sacroiliac.
That's maybe a good point. That's a good point. No, because I was carried away because he is referred by the rheumatologist. He's a qualified one. So I thought he must have excluded rheumatology conditions. But I did not even look at the blood report he said because he said, no, you're a rheumatology problem. And you go to the neurologist. That's what he said. And I was only thinking in that lines. Subsequently, when it did not improve with Neurology and things like that, I wanted to re-examine. Okay, shall we close?
Okay, good night, sir.
Good night.
Good night, sir. Good night, sir.
Good night.
Thank you, sir. Good night.
Right, sir. Good night, sir. Thank you.
Good night.
Thank you, sir.
Nice case.
Thank you, sir.